Hello, my name is Leen, and today we're going to be delving into this presentation, Intersecting Identities on Equal Access. Just for the purpose of this presentation, the terms therapy and counseling are going to be used interchangeably, and we're going to be looking at specific barriers. So just as a quick outline, we're going to be looking at why this research matters, what we already know in this field, the methodology that was used for the study, the results and the discussion, and finally the implications and the take-home messages. So relationships are fundamental yet challenging, and the juxtaposition between our need for relationships and for communication as human beings and the difficulty, the challenges, the misunderstanding that can come with that is where my interest lies in terms of not just communication, but also in couples therapy. Understanding why it matters goes back to something so fundamental as the evolutionary theory, which talks about why we evolved as people. And looking at the fundamental social motive theory, the study by Pick et al. Actually looked at over 40 countries at two different points in time, and looking at how vital it is, our communication and relationships, that it affected um, the most basic things like self-protection, affiliation, mating, and even status and other aspects. So, and this also lends us to the attachment theory, which beyond romantic relationships, also in parental relationships, we see that secure relational bonds are so fundamental, and not having them can have such extreme psychological consequences. In terms of what we know, talking about those consequences, there's the relational distress. We know that having a communication breakdown in relationships is connected to poorer mental health outcomes. We know that couples therapy, different forms of couples therapy that I won't delve into, helps individual well-being as well. So if we're looking at the barriers for some people accessing, couples therapy, we're seeing two forms of barriers that affect accessibility in terms of access, as in getting your foot in the door, versus engagement, which is having that block once you're in the room, and trying to get that counseling. So, what we know about exclusion. So if we're looking at LGBTQ plus couples and ethnic minority clients, we've seen that there are common relational challenges that can overlay with what exists. But then there are also minority stress that comes with being an LGBTQ plus person in a relationship, especially when it comes to therapy and thinking that, are these modalities actually created for me? And then there's also the ethnic minority side, where in certain cultures, the stigma of going to therapy can be a lot higher. There can be, there's research out of Saudi Arabia that shows a lot of shame around this and some systematic lack of competent therapy providing here. And then there is the intersection. So when you have someone who is part of the LGBTQ plus community and of an ethnic minority, how is all these different aspects that we see as these separate pieces of the puzzle, how do they come together? Um, and we know that that exclusion exists. So let's talk a little bit about the gap. So this gap exists, as it's shown by McGurry, that the majority of the research has been done on white heterosexual couples. Even Hubbard et al., as previously mentioned, 75% of the participant groups were white heterosexual people. So what is missing in this research, in the research itself? The intersectional frameworks that we discussed, culturally and LGBTQ plus adapted therapies or interventions, research centering around dual modality, the intersection between these two people, and clinician training for intersecting. So that leaves us with the research aim of understanding and exploring the intersecting barriers and positing the question, how do ethnically diverse LGBTQ plus individuals experience barriers to couples therapy access? So let's talk a little bit about the methodology. So our participants, we had 9 participants. All of them were aged between 24 and 52. They self-identified as part of the LGBTQ plus and of an ethnic minority. We recruited online internationally. Using social media and word of mouth, and all had considered going to couples therapy at some point. The data collection was a demographic questionnaire, and then that led to semi-structured interviews that we conducted. And some of the topics are mentioned. The analysis was Braun and Clyde's 6-phase thematic analysis, which we then transcribed using intelligent verbatim. And finally, the ethical consideration was there. We got the community ethics approval from Bangor University themselves. This was also aligned by the BPS and the BACP, and there was definitely some distress protocols in place in case any of the participants needed it. And there was definitely also a debrief with the participants. So let's talk a little bit about results. So there was 4 results, 4 themes that came out of these. Here we're going to look at some of the quotes and then we'll delve into them. So if we're looking at logistical barriers, more than the sum of its parts, we're looking at financial and practical access. The main barrier is financial. The other one would P1 saying, I would rather it be led by me in terms of timing and scheduling. Value and willingness, the concern of investing energy and money and not seeing a result. So the investment was more than just putting in money, it was also about putting in time and effort. And there was also partner willingness. Is my partner willing to go with me to counseling? And if they're not, what does that mean? Therapy place within culture, client, and therapist. So the first theme, cultural stigma, there was talking about even being seen, as P4 mentioned, being seen going into a therapist's room came with a lot of stigma. So what does that mean? And then family pressure. So personal matters should stay private. This existed slightly in the research out of Saudi Arabia, seeing a lot of shame and guilt of taking problems outside of the family. And then therapist positioning. Am I going to get a therapist that actually understands what it means for me as a person of cultural minority that I'm here in like seeking out therapy? The other 2 themes, 3 and 4, theme 3 was experience of being LGBTQ plus in the therapeutic space. So there are 2 sub-themes here, fear of therapist perception bias and the desire for a knowledgeable therapist. Um, is this treatment actually going to be modeled for me, or is it going to be a heteronormative treatment? And is this therapist going to judge me, or are they going to know what it means for me as part of the LGBTQ plus? And the intersection between these, cultural belonging versus sexual identity, how did these 2 connect? Were they just, you know, adding them together, or did one come up before the other? So we'll definitely see that one does come before the other. And the lack of representation and visibility, there was a participant who said, when I think about couples therapy, I think about straight white people. So it didn't seem that I would belong there. So that was very interesting. These barriers did not operate independently, as we're going to see. So the cumulative weight of logistical barriers don't stack, they compound. Fear of putting in money was not, oh, I'm going to lose my money. It was, what if I invest? What if I put in the effort? What if I put in the time and the money and not see this result that I was supposed to see or that I wanted to see? And that really does show us some of the research that already exists, but also adds this extra layer The other aspect to this was partner willingness. We saw that it was quite didactic. If a partner was not willing to go to couples therapy, that kind of stopped everything in its tracks. So one thing did come before the other. There was a prerequisite of, is my partner willing to go? Yes, then I'll go. No, then it's kind of a no-go. In terms of the weight of cultural stigma, so socially enforced norms, the research with our participants really showed us that there's this extra layer of weight that comes to going to counseling when it's not considered a social norm. Family honor and double secrecy, there was a lot of shame of I'm taking my problems outside of the family, and double secrecy. We had one participant who particularly stated that if I'm living with my family and I'm going with my partner to couples counseling, then I would have to hide. I would have to lie to my family about where I'm going. So there's this added pressure of having to live in this lie to be able to seek help, and worrying and thinking about, is this therapist culturally competent? Are they going to actually understand my experience and what it actually means for me to be here? Fear of judgment, desire for affirmation. So we saw in theme 3 that there are certain barriers for people from the LGBTQ plus that think about safety in ways that haven't really been shown in the research before. Am I in a safe place? Am I being actively accepted? Or there was one participant who said, I'm 99% sure that I'm safe, but there's still that 1% in my head that's thinking, is this person judging me? And also thinking about the level of tolerance, and also, does this psychotherapist know how to work with me, or are they going to be using heteronormative models? Finally, the culture and sexuality, a hierarchy of safety. And this is one of the biggest findings that we found. Cultural safety comes before sexual identity for the participants that we had. And that means that, and if we can see that in the quote, if I come out loud and proud being as bisexual, but the culture around me doesn't support me, then there's no way I can express it or live it serenely. So I would need the culture and the society to support me first before I can then come out and live as part of the LGBTQ plus out loud. And that coming together was not just a matter of these two things coming together. It showed that one of them superseded the other one for our participants. So understanding that means understanding the clinical implication for us as psychotherapists, that because it's not just the sum of its parts, then there's an identity negotiation. Who the person is who comes into our room, be it LGBTQ plus or a cultural minority or both, is not a background to their character. So we'll look a little bit about how this theoretical shift sits, and the framework can be reimagined through the proposed reimagined Lewis PG model, being client-led and not diagnostic, and zone-based clinical implications. So thinking about what must change in practice. So a really important aspect is integrated training. There's a lot of training that puts working with someone who is from an ethnic minority or LGBTQ plus as part of the CPD, not part of the training to begin with. Whereas having it integrated would be very important for our understanding. Visibility and representation, this was mentioned quite a bit by the participants. So thinking about where representation actually exists and what amount of inclusion is there. And starting with a model. So the Lewis model, this is something I like to think of in a certain way. So two businesswomen are in a conversation. One of them, woman A, is very expressive. She's using her hands. She's being very passionate. And woman B is measured, analytical, and precise. which of these women is the Italian and which of them is the German. And most people most people would say that woman A, the very passionate one, is the Italian and woman B is the German. And we'll see why that is with the Lewis model. So that scenario kind of explains that this Lewis model looks at cultures and countries based like and sees behaviors, common behaviors. So as we saw, the multi-active person would be the Italian, and we actually saw this from one of our participants, saying that I don't only think that works for cultural settings, but also for therapist setting as well. Um, so it feels that I can place myself on this and communicate. So while that's very helpful, there are critiques to this model, as there is with any, that argue that not only does the Lewis model not account for crossover if someone is half Italian and half German, and then also not every Italian is going to be expressive that way. Maybe it's a bit too generalized. The However, for those that it does work for, this reimagined Lewis BG model will try to take it a step further in imposing on it two aspects of being part of the LGBTQ+. It looks at the country or the culture's social acceptance of LGBTQ and the legal acceptance. So if we're going to take Germany for an example, Germany is of high legal protection and high cultural acceptance. So this model in practice between a psychotherapist and a client would work as the psychotherapist presenting this model and the client placing themselves in one of the zones. This does not replace or get rid of the problem of not understanding intersectionality, but it does build a bridge as a starting point. Hopefully, this is where future research would have to come in to come and try to understand if this could work for clients. But this model was it was adapted for this research and for this purpose. So, looking at limitations and further research. So, the limitation that we saw is this research really broadened our understanding of barriers to couples counseling in a collectivistic culture because 5 out of our 9 participants are actually from India. But also it's limited in that it lets us know more about India, but it can be for future research be replicated in other countries to see if the same findings, would appear. And also this replication could take us a step further. So the take-home messages, thinking about compound barriers, it really highlights both integrated competence and compound barriers. I think it's important that we kind of have this framework of seeing things so separate from each other. So when we talk about competence, we talk about cultural competence, or we talk about LGBTQ plus competence. We don't talk about them as in together. And while there is research talking about that competence, I think it's important for us as counselors to realize that these things do need to be integrated, and how they get integrated and why does tell us about compound barriers, because knowing how it works for the client means us knowing how it's going to how it's going to have to be translated or working for the counselors. The other two are also quite connected in terms of systematic change and new frameworks needed, because both of these concepts can seem so large for one psychotherapist. But if we're thinking about systematic change, we're thinking about what needs to be changed from the top bottom. And in just knowing those things, we can challenge them. And then new frameworks being needed is something that I think is that can happen through communication to come full circle. And that's an age-old thing that new frameworks comes from the old ones and how they used to work and what's missing and how they work in the future. So that's something that we can always be taking into our work. Thank you so much for your attention and engagement with this research. If you have any questions, please feel free to pop them in the comment section and I'll try to respond to them as soon as possible. And in terms of references, I'll be showing the next few slides. Please feel free to pause and peruse as you see fit.